Ladies and gentlemen, dear colleagues, welcome back from the coffee break. And first of my name is Eftimios Chatzitheoklidos. Don't try to remember or to learn. It's more than 50 letters. It's also not difficult to pronounce, even to write down, because it's wrong. It's written wrong. And they just call me Mike. That's enough. I am from Selanik. I am from Thessaloniki, Greece. Close, very close to your country or to your countries. And I'm very happy to be here. I would like to thank my Kardeşim Ahmed Choker for this kind invitation. He's a long-standing brother, more than friend. And I would like also to thank him because he gave me the opportunity to chair the lecture of Professor Mustapha Adam. And it's a great opportunity for me. It's an honor for me because I had the chance, the opportunity to listen him to a couple of times about this subject. And I was impressed. The last time was in Athens. And he will deal with his presentation is about ERAS, or in other words, fast-track surgery, focus on pancreatic surgery, an issue that has a lot of controversies, and I hope that he will clear up everything about that. There is a gap between theory and clinical application of this issue, but it's very important because save lives, money, and time. Please, Professor Adam, he is from Lyon. Be careful.
Thanks, Mike.
Okay.
You were safe.
You are right.
Yeah.
Don't try
I
more.
would like to thank also my friend Ahmed for his invitation. It's a great pleasure to be here in Izmir. It's my first visit to Turkey also. I'm very happy also to have such an expert floor, and I hope that my presentation will give you more insight about the enhanced recovery after surgery program. So we will focus on the pancreas surgery, but I will give you some overview of the presentation. We will see what is the ERAS, the challenges in pancreatic surgery. We will see if it works, the causes of failure, and how to succeed an ERAS program. First of all, you know that over time, the practice in surgery, I see just the pointer. So we don't have a pointer? No? Okay, anyway. Changing in practice happened always in surgery. If you look in the 60s, the one-day surgery was developed in the United States. Ah, yeah. It's okay. One-day surgery was developed in the United States, and it was like frequently is money-driven. We reduced the stay in the hospital to reduce the expenses and the health cost. Then in the 80s, laparoscopy was developed. It started with the laparoscopic cholecystectomy, and then it became very popular in surgical practice. And because of the development of laparoscopy, at the end of the 90s, we had the concept of the fast-track surgery. And then in the past decade, we have development of the enhanced recovery after surgery program. So frequently, we have many confusion when we're doing laparoscopy, when we're talking about fast-track, and then we are talking about the ERAS program. If we ask in a setting of 100 persons, who knows ERAS? Everybody will say yes, 100% responder. If we ask who do ERAS, only 40% will say yes, we do an ERAS program. And if we go in the department and we look what is really done, it's only 1%. So maybe as surgeon, we think that we are stronger than what we really are. frequent mistake is that we think by doing the fast track that we are doing the ERAS program. The fast track was developed by the end of the 90s. I'm sorry about some of the picture because it was done on a Macintosh and Apple, and on PC it's not always the same. But the main objective of the fast track was to reduce the health cost, the money we spend in operating and treating patients. And the way to do it was to do the minimally invasive surgery. So you do laparoscopy, the patient will stay less, probably will have less complication. This is what we think about the fast track. And the outcome is to reduce the length of stay, reduce the cost of the surgery. But the inconvenience to do the fast track, you have to select the patient. So if you want to do the laparoscopy, we choose a patient which is fit for the laparoscopy, no so big comorbidities, etc. And on the other hand, we have an increase in readmission. So the fast track is not possible for all the patients we are treating. And when we do the fast track, we increase the rate of readmission. In some report, it's up to 20 to 30% of readmission. So it's not useful to let the patient go home early if he comes back 2 days later. So we have to draw a new limit for our practice. New concept, a patient-centered care for a better patient outcome. And this is what is the main point in the Enhanced Recovery Program is, as a surgeon, we are not looking about finance. It's not my problem is the hospital get money enough or lose money. My main concern is the patient outcome. If the patient is doing well after surgery, we will gain on all the level. So the objective of ERAS, it's not the money, it's not the cost, it's to improve the quality of care and to put the patient in the center of the treatment and make the patient an actor of his treatment. The way to do it is to reduce the stress around the surgery and to reduce the complication. And this will lead to a reduce in the length of hospital stay, decrease in the health cost, and without increase in patient readmission. It's the opposite of the thinking and the idea of the fast track or the one-day surgery. So it's a perioperative multimodal care pathway with the aim of early recovery of the patient. We have to re-examine our traditional practice on evidence-based medicine and covering all the area of the patient journey without patient selection. If we select the patient, we are not doing the ERAS program. The ERAS program should be done for all the patient. And you will see more the patient had comorbidity, the more he will benefit from the ERAS program. As I say, if you take a young boy, you operate from inguinal hernia, 2 hours after surgery, he's running in the ward, and the next day he's playing football. If you operate a patient at 85 years old from an inguinal hernia, he will not be walking 2 hours later. But if you do the ERAS program, the patient of 80 years will benefit more from it than if you select only the fit one for this program. So when it started first in 2001 by academic group, anesthetist from Edinburgh, who passed away last year, and a surgeon from Karolinska, Kinfiron and Oli Lundqvist. In 2010, the ERAS Society was created, including other faculty from all around Europe. So you see, it takes 1 year to change. I would say it takes more than 10 years to change things. So who wants to win millions? If I ask you, prehabilitation, the concept of prehabilitation was reported first by Flintstones, by the Second World War, after a meeting of presidents from all over the world in 1962, or in 2014 by a recommendation from the WHO. So I just think about the answer. In fact, prehabilitation started after the Second World War. The Army of Her Majesty in UK want to recruit new soldiers, but they were facing problem that all the young men had physical problem and weak mental health. So they didn't know how to solve this problem because the army had lost a lot of men were killed during the war. And to build a new army, it was very complicated with this problem. So they put the program of prehabilitation with giving good housing, good sleep, good health and eating, and a lot of sport. And they found that by doing this, the young men improved their physical performance and even their mental performance. So prehabilitation started after the Second World War in UK. And it's more than 50 years now. We are starting to talk about prehabilitation in medicine. Second question, this you will not get money, it's only to be a champion. The concept of pain control, surgical site infection prevention to shorten patient preparation and decrease length of stay. Started in the 18th century, 1965, 1985, or 2005. Choose an answer and you will see if you are a champion or not. In fact, the concept started in the 18th century. This is Claude Poutot, surgeon in Lyon. He was working at the hospital called Hôtel Dieu, and he found that patient had a lot of infection. The patient came to the hospital several days before surgery. They stay long time in the hospital for their preparation, and they have a lot of pain, and they had a lot of sadness, stress, and a lot of infection, and finally a lot of them died after surgery. So he thought that if we shorten the patient preparation by making the patient to come to the hospital on the same day of the surgery, use sort of disposable materials, so the patient dressing, etc., are used for only one patient and then they are thrown away, and the patient will stay as short as possible in the hospital, so he will get less infection, and he, by this way, decrease the rate of death. He didn't have evidence-based medicine. He just thought that it must be true, and he was right. This was in the 18th century. So you see, same problem we are discussing today were the same too long ago. So ERAS guideline, ERAS Society published guideline on different type of surgery, the colorectal surgery, the pancreas, and then you have guideline also for gynecology, urology. Now we have for the liver, etc. And you have all these guidelines on the website. They are free of for downloading all the guidelines according to your specialty. So what are the goals of ERAS? If you look to the recent data, these are from colorectal surgery, you see that the rate of complication will decrease with the increase in the compliance. The more you have compliance with the ERAS program, the less you get complication. And this is evident. You see the higher rate of complication if you are less than 50%. If you are more than 90%, rate of complication will decrease significantly. Also, length of stay and readmission, you see the higher the compliance, you have less day of stay in the hospital, and you also decrease the rate of readmission. The objective or the aim is to be above 70%. You can never be at 100% because the ERAS program should be adapted for each patient, and maybe some items could not be applied for one patient or another, so it's never possible to be at 100%, but the cutoff level is more than 70% to get the best results. We also have data on colorectal surgery that if you increase the compliance above 70%, you improve the survival. And this is very important because whatever the treatment you give after surgery, chemotherapy, or whatever, you see that if you improve the post-operative care, if you have less complication, you improve the survival of the patient. And this is very important data for the future of our practice. And also it's cost effective. However, the cost is very different from one country to another, so we cannot compare it, but all the studies done show that there is a cost-effective issue by using the ERAS program. So ERAS in pancreatic surgery, as we said, it's a protocol centered on the patient. You have items in the pancreas, 20 items to be applied. Some of them are pre-operative or intraoperative or post-operative. The most easy to apply are the pre-operative and the intraoperative items. So this we will have very high compliance rate on it. The post-operative is more complex to put because after surgery the patient sometimes is not very well to go and walk or stay enough time outside the bed, etc. So more difficult in the post-operative period. You can also classify them according to the patient journey. Some items should be proposed and done by the surgeon. The patient information, no bowel preparation for pancreatic surgery, incision, small incision, no nasogastric tube, no drain, laxative should be used, early oral feeding. For the anesthetist also, patient information, no pre-anesthetic medication, carbohydrate load, early feeding, fighting hypothermia, epidural anesthesia, perfusion should be targeted perfusion, not to give too much fluid, post-operative nausea and vomiting prevention, oral analgesic and no opioid. And you see information is always present all along, and then we have the paramedical team should also participate in the patient information, education, early mobilization, and early oral feeding. So all these items are done during the ERAS program. In pancreatic surgery, we face several issues which causes problem for pancreatic surgery and are sources of complication. Part of it is undernutrition. You see on the upper part of the curve is pancreatic surgery, and the lower part is the colorectal surgery. So you see that undernutrition is higher in pancreatic cancer patient than in colorectal cancer patient, and in consequence you have more complication in pancreatic cancer because of the undernutrition. So we have high risk because of undernutrition, and also the patients are older. Most of the patients we operate for cancer are more than 75 years old. In the ERAS program, we recommend no systemic preoperative artificial nutrition. Immunonutrition should be given 5 to 7 days before surgery. We look to our data we choose for a 3-year period, 336 pancreatic cancer patients. When we look to the mean BMI, it's not very low, but the total loss of weight for these patients were more than 1,500 kilograms. Each patient lose average 5 kilograms, BMI less than 20 in 15%, albumin below normal in 1 in 4 patients, and prealbumin below than normal in 36% of patients. And if we look to undernutrition according to the NRI formula, we have only normal nutritional status in almost 25%. All the other pancreatic cancer patients had either slight, moderate, or severe undernutrition, and this is not related to the age, whatever the age of the patient. If you look to the recommendation of the ESPEN guideline for nutritional support, preoperative, severe malnutrition is 10 to 14 days prior to major surgery, and immunonutrition can be given 5 to 7 days before upper abdominal surgery, only for cancer, not for other type of surgery. And post-operatively, malnutrition also should be taken care of with oral intake, 60% of nutritional requirement at least by 10 days. So you see that the most important thing in the treating the undernutrition, first line is oral nutrition. Oral nutrition, not parenteral nutrition or not whatever. As long as the patient can eat, he should get good food, and then he can have more complement or supplement of the nutrition. It's only that patient who cannot have enough oral food or have very severe undernutrition should benefit from parenteral nutrition. So these are the recommendations today, and they didn't change so much compared to the previous one. Second problem is the pancreatic head cancer and jaundice patient. Jaundice is quite a problem because it can be source of infection, cholangitis, can also be source of malnutrition, can be source of immune deficiency. So it was a long time a practice, and even until now, to have preoperative endoscopic biliary drainage. A randomized study was done in the Netherlands. You know all about it. They showed clearly that preoperative endoscopic biliary drainage increased the complication. The cutoff was 250 millimole of bilirubin. And they recommend that preoperative biliary drainage should not be performed routinely when the bilirubin level is below 250. But if you have 300, 350, what we do, we don't have the answer yet. We looked to some data in our center, and we said, okay, if the patient had cholangitis or whatever complication from biliary obstruction, there is some necessary indication or good indication of biliary drainage, okay? But many patients had unnecessary biliary drainage. So we look for the patient with high bilirubin level without formal indication of drainage. We found that almost half of the patient will have unnecessary biliary drainage. And when we compare the result, the complication, overall complication in the group unnecessary compared to upfront surgery, you see we have the grade 3 and 4 according to Clavien, the complication, almost double. If we look to include the mortality, always much higher in the unnecessary preoperative biliary drainage. And if we look to only the post-surgical complication, only related to surgery, you see we have also higher complication when the patient had unnecessary biliary drainage. So the best is to offer the patient upfront surgery and avoid as much as possible to have stenting. And recently we have some data from a study we are conducting now in France that the self-expanding stent might compromise the oncological outcome. This was shown in esophageal cancer, and we have some early results from a study in France showing that it should be the same for the pancreatic cancer. We also found that putting a biliary stent will delay the time to surgery. If you have the patient, if you see the patient for surgery, the average time for upfront surgery is 28 days in France, from time of diagnosis to time of surgery, okay? And when the patient has biliary drainage, it's almost more than 2 months before he gets his surgery, so maybe he is too advanced and cannot be operated. And we also found that some patients, almost 8% of the patients will become unresectable because they have complication after biliary drainage. They have acute pancreatitis, they have duodenal perforation or whatever, and then you delay the surgery, and when you operate the patient, they have frozen abdomen, and the resection cannot be done. That we don't see when we perform upfront surgery. Preoperative fasting, we had always been educated that patient must be fasting before surgery, but we forget the physiology because the stomach empty within 2 hours, so the patient can have liquid or carbohydrate load until up to 2 hours before surgery. And making the patient fasting before surgery will increase the stress and will increase the insulin resistance and will jeopardize the post-operative outcome. So the ERAS recommendation is to give carbohydrate load until midnight, 800 milliliter, and then 400 2 hours before surgery. So you can have either the pharmaceutical product, and if you don't have, you can just give apple juice for the patient. It can almost do the same. So this it was shown that it does not increase the problem of complication after surgery. So you see the recommendation of the ESPEN guideline, preoperative clear fluid until 2 hours and solid food until 6 hours before the anesthesia, carbohydrate load the night before and 2 hours before surgery. And post-operative, we have to start early oral feeding as early as possible. The stress. We usually give pre-medication because we think that the patient is very stressed or he must be very stressed, so we decide frequently for the psychological condition of the patient, which we don't know anything about. The best way to avoid stress is the patient information. You see in the ERAS program, the surgeon gives information, the anesthetist gives information, and the paramedic gives information, and there is a dedicated outpatient clinic with the nurse, ERAS nurse coordinator. She spends more time with the patient, giving him all the explanation, all the information he needs, and he can ask more questions than when he is with the surgeon or the anesthetist. Patient education, carbohydrate load, and pre-anesthetic medication. As you can see, this patient is walking to the OR. He was planned to have pancreatic resection and left-sided hepatectomy in the same time, and you see he's not stressed at all because he had all the information about his surgery, about the possible outcome, possible complication. He has no stress at all. We use this for all of our patients. Waiting time in 95% is less than 10 minutes, and almost all the patients are very happy by this way of preparing their surgery. Intravenous fluid, we use also to have patient with a lot of fluid passing during surgery, and the more the surgery is complicated, the more the patient gets fluid from the anesthetist. And we know today that this increases the complication. It was shown in colorectal surgery, in esophageal surgery, and now in pancreatic and liver surgery also. So we have to adopt the guided policy to improve the perioperative outcome, so not to perfuse the patient. We have to find the balance, and the best way to do it is to use the transesophageal Doppler. The anesthetists are very good in evaluating the need of the patient for perfusion during the surgery. And as you see, this is the left column is the before the ERAS, and the right one is after ERAS, and you see that we decrease significantly the amount of fluid we give to the patient, and this is very important because it reduces the post-operative complication. Another issue in the pancreatic surgery is the abdominal drainage. We have now 4 randomized control studies. The last one was published recently on the distal pancreatectomy. Two of them, or even the third one, say that systematic drainage is not useful. Only one from the United States were stopped because the patient with Whipple had higher rate of death, despite the results were not statistically significant. The study was stopped. So there is still a debate whether we have to drain or not to drain. But the question is not to drain or not to drain, to drain or not to drain. The question is, should the patient be drained or not? We have to make our treatment centered on the patient. If you have the patient with high risk of fistula, you may say, okay, maybe this patient will need abdominal drainage. And if you have a patient with low risk of fistula, with chronic pancreatitis, large main pancreatic duct, maybe this patient will not need drainage. So today we are going, I think, more very selective drainage rather than I always drain or I don't drain at all. What we should know that if you drain the patient, you have to remove the drain early according to the level of amylase in the drain. And we should, I think, all think avoiding routine drainage. We should adopt selective drainage according to the risk of fistula for each patient. Pain control is very central. If the patient has no pain, he can go out of the bed. This is patient, young patient, Whipple operation on day 1. He's out of the bed walking, you know, in the morning. And this is another patient, 82 years old, few hours after his surgery. So we are in the day of surgery. He's already out of the bed, sitting, maybe sleeping a little in his chair, but he's out of the bed on the same day of surgery. So this is very important. Pain control will allow early mobilization, early feeding, early bowel motion, and the analgesia should be with epidural whenever possible and should be multimodal. Avoid opioid, as we said. Control the nausea and vomiting. You see the patient has no nasogastric tube. The nasogastric tube is used only during the surgery and is removed immediately at the end of surgery. If we look to the early oral feeding, in Whipple procedure, say we have a lot of anastomosis with the gastrojejunal or pylorojejunal, the hepatico-jejunal, the pancreaticogastric or jejunal anastomosis. So the surgeon are always afraid of giving patient to eat. We have several studies comparing oral feeding to the other way, and we saw that early oral feeding will decrease the hospital stay, and there is no increase of anastomotic leak when you use oral feeding. So what type of nutritional support we can give for the patient after pancreaticoduodenectomy? As I said, the surgeons are always afraid because we have a lot of anastomosis, so we say we should not give oral feeding. We should use parenteral nutrition or nasojejunal tube or jejunostomy tube feeding. So all these were compared, and you see different, many studies were reported. Most of them are very low number of patients. You see 35, 32, 73, 28, 30, 40 to 30 patients. And results are always different because the aim of these studies were not always the same. So the first one showed that immune-enhanced enteral nutrition is superior, and there is no difference between standard enteral nutrition and TPN. The third one showed superiority of standard enteral nutrition. The fourth one, no difference. And the last one is the study we conducted in our center comparing the jejunal feeding to TPN, and we showed that TPN is better than jejunal feeding, especially in Whipple operation. And you see we have the more complication in this. Length of stay also in our study was shown to be better in TPN compared to nasojejunal feeding. But this study was done before the recommendation of the ERAS program. We also found higher rate of nasojejunal tube removal and time to start oral intake in the TPN group. When we look to the published data, we have compliance in the ERAS program, which are very good for bowel motion, oral feeding, stopping intravenous fluid, early mobilization. If we also look to the outcome, we have improved morbidity after the ERAS program without increased mortality and without increase in the readmission of patient after ERAS program. Even if we don't do the full ERAS program, as you see in the middle of the slide, if you do an ERAS-like program, you also improve the outcome. So this is the era before the ERAS-like or the ERAS program. As long as you implement some of the item of the ERAS program, you will get better result. As you see in this data, you see you improve the outcome of morbidity and mortality and length of stay before and after the ERAS program. Also, the 30-day morbidity, mortality, length of hospital stay in this study showed the same outcome, improving the results comparing ERAS to the control. If you look also to the health cost, you see that in different type of surgery, pancreaticoduodenectomy and total pancreatectomy, distal pancreatectomy, etc., we have an improvement in the health cost when using the ERAS program. So how to improve? First of all, we have to be modest, not to think that you are stronger than what we are, and we ask an expert team to come to visit our center, and we called the team from Lausanne of Nicolas Desmartins, who came and he helped us in implementing the ERAS program. It takes about 9 months to implement the full program, and you see everyone do some of ERAS. So this is, before we started, we had about 43% of the ERAS item were done in the department, and after the ERAS implementation, we raised to 86%. And you see that the compliance shift to the right, so we are improving our performance. And if we look to the compliance of pancreatectomy, these are the data we have. So you look to the compliance rate, and if you found that you have as abdominal drain, we are not very compliant, 50%, but it is normal because probably we had more patients in this period who had high risk of fistula, so we use abdominal drain. You see also that you increase the compliance, you decrease the length of stay, and we also see that our outcome, the outcome of the patient improved before and after ERAS, we decrease the complication. The major complication grade 3 and 4, we reduce the 90 days mortality significantly. Fistula also decreased, hemorrhage, reintervention rate, and length of stay decreased from 26 to 10 days. Readmission rate is only 7%, which is quite acceptable for pancreatic surgery, and rate of reintervention, as said before, is lower. One of the most important things is that you can better control the bed in the hospital. When you operate the pancreas, sometimes the patient should go in ICU or high dependence ward, etc. When you apply the ERAS program, you see the curve on the upper one on the left and the right. You have less variation after the implementation of the ERAS program, so you have a better management of the bed in your hospital. And if you see the graph on the lower right side, you see that we have less patient going to ICU and more patient coming back directly to the surgery ward. And now it's very rare that the patient go to ICU after Whipple procedure, almost 95%, unless they have heart failure or something like this before surgery. All patients come back to the surgery ward, so we have better management of the different beds in the hospital. If you apply the ERAS program for one type of surgery, when we started with the colorectal and the pancreas, but all the other were supposed to be in the normal path or the previous path. But in fact, you improve the outcome of all the patients in your ward. This is the length of stay. We started in 2013. We have 2 wards, one for HPB, one for GIT and bariatric, and you see that even when you don't apply ERAS in the other type of surgery, you reduce the length of stay. You see from 7.3 to 4.2, from almost 6 to 5, so you gain in all the patient you treat. How to succeed ERAS? You have first to say we need no more dogma in surgery. We have to change the practice. We have to define our goal. We have to audit and analyze our data and result in the balance of patient interest and the health economy. So it's an integrated protocol. It's a way of preparing all the patient journey before, during, and after surgery. The implementation program is a standardized program on 4 seminars with some homework for each team to be performed. And then you start the implementation. You organize a team with surgeon, anesthetist, and paramedical. You have the guideline. You have to write your own protocol. The ERAS don't give you the protocol. They give you some guidelines, and you have to write your own protocol for your program. You have to organize the data collection. You start the implementation, information of the team, education of the team, and collection of the data. And then you have to adjust your practice by data analysis, auditing. You see the compliance, and then you adjust your practice. You have also the patient roadmap. The patient is very active in his treatment program, so he has also his own homework to do to be part of the treatment. And then you can, if you wish, participate to the interactive audit system of the ERAS Society. It will give you all your compliance rate. It gives you all your complication, etc. You need to, of course, to enter the data, but you can follow all your results, and you can see if you are having sufficient compliance, if you have increased complication or less complication, what is not working well, and you can adjust your way of doing things. And as I said in the early, you see the pre-operative compliance is always very high, 95%. Intraoperative compliance is a little bit low, around 70%, and the post-operative is the lowest, is around 45%, because it's more difficult in the post-operative. The surgeon and the anesthetist are the champion for not respecting the item, okay? Because we have a lot of dogmas, all of us. We don't want to change our practice. We learn this way. My mentor do it this way. He had very good result. Why should I change? Okay, so it's very difficult for surgeon and anesthetist to change their practice. Then the patient is on the second, and the most performing are the paramedical nurses, are the less to be subjected to opposition for the ERAS program. So it's really a patient-centered care. It does not include only the medical treatment. It includes all what is around socio-economical aspect. Everything happening is included to get the best outcome. So it's like the old world and new world. You see, this is the Formula One. This is on the left side is 1953. And on the right side, I think it was maybe 10 years ago. You see, to change the wheel, both are the Ferrari team. They take 3 seconds to change the 4 wheels. And here in 1953, they're still changing 1 wheel, and they didn't finish yet. So this is the way. You see the number of people working now. This is a bigger team. Everyone knows what he's doing. It takes 3 seconds to change the wheel. So this is the new world. This is what we should be doing now in surgery, to develop a program. Each one should know what he has to do. And now we are going very fast. Still working on this other thing. So in conclusion, to succeed the ERAS program, you have to get a proper implementation. You have to follow your compliance, to accept, to change your practice and of dogmas. You have to put a sort of coordination program, and especially a teamwork. Thank you for your attention.
Thank you, Professor Adam, for this outstanding presentation. And I think that most of us are surgeons, so we gained the gold medal of resisting to apply the ERAS program. And I think that there are many questions, answers will be, and don't feel a complex of inferiority to say that you will never perform all this kind of what ERAS is trying to apply. And please, it's open for discussion, the presentation. Okay.
Thank you for your good presentation. I want to ask about exact time of drain removal if we use drain, and which factors are risk factor for pancreatic leakage that we need to drain in operation time. Is it age one of the risk factor other than size of pancreatic duct? And do you check the amylase of drain routinely in your practice or in your protocol? And the exact time of oral feeding, I want to know.
For the drain, one is a very important question. We have different risk factor published in the literature, how to evaluate the risk. But what we apply is very easy, is the size of pancreatic duct and the texture of the pancreas. If we have one or the other soft pancreas and or small duct less than 3 millimeters, we put drain. Otherwise, we do not put drain. And if we put the drain, we always put 2 drain, because we change it several times, the way we put the drain, the type of drain, where we put the drain, because this is very important also. If you put drain, you have to know how you put them and where you put them. So we usually put 1 drain above and 1 below the pancreatic anastomosis. Okay, 2 drain. And we measure the amylase level at day 1 and day 3. If the level is less than 5,000, we remove the drain. However, we also look to the amount of the amount of liquid that we drain. If it is very high, more than 100 milliliter per day, we keep the drain until day 5, and then we decide to remove them or not. Okay. So we only use the size and the pancreas texture for draining or not draining the pancreas. Oral feeding in the ERAS program, when the patient comes back in the ward, even in Whipple procedure, we offer them liquid, okay, so they can drink. And on the next day, they start oral feeding. They can have some yogurt or whatever, something light, and then we always say to the patient, you, the one who decide. We propose to you, and you decide if you want to eat or not. Okay? They should understand that oral feeding should be self-driven. It's not an obligation. He should not finish what you give him. Otherwise, he will get problem. Okay? So he eat. If he's fine, he eat. If he's not fine, he stop, and then he will go later on. So we start oral, liquid on day 0, and oral feeding on day 1.
Do you have any standards to put or not to put nasogastric tube, the gastric delay syndrome?
No. So the nasogastric tube, we remove it at the end of the surgery. And what happened? We just remove it for all patients.
Or for all?
For all patients. Then we found that we put the nasogastric tube too much. Okay? And then we looked to our data, and we found that we put the nasogastric tube on day 2 or day 3 in 40% of the patients. 40%. So we were very worried. So I called Nicolas de Martin, my friend. I said, your ERAS program is not working. And he said, yes, but we also put in 40%. But in 60%, we don't use the nasogastric tube. So you have to look, you keep the nasogastric tube in 100% of patients, or you avoid it in 60%. So we prefer to avoid it in 60%. And what we do now is we do a plain X-ray of the abdomen at day 2. We don't wait that the patient vomit. And if we found the stomach is full, we put the nasogastric tube, and usually we keep it for 24 or 48 hours, and then it resolves. The problem with delayed gastric emptying is when the stomach is too much dilated and the patient at the point of vomiting, and then it takes longer time to be settled.
Yes. Yes, please.
Thank you for good presentation. I have a couple of questions. One of is, do you use the somatostatin or sandostatin analog for high risk pancreatic fistula? If you use, how to use to the ERAS protocol this patient?
Okay. Yeah, there's big debate on some are pro and some are against the use of octreotide. We usually use somatostatin in high-risk patients. If we have soft pancreas, small duct with 1 or 2 millimeter, we use somatostatin. We leave it for 6 days and we stop it half dose on the 7 day. But it does not change anything on the ERAS program. The only thing that the patient, when he walks, he has to be with his perfusion of the somatostatin.
But early enteral nutrition?
They all have oral feeding, even if they have somatostatin.
Excuse me, not all. Professor, not all. 40% they don't have early oral feeding because they have reinsertion of the nasogastric tube.
Yeah, they start on day 1,
okay.
But if they have gastroparesis on day 2 or 3, of course we stop.
Okay, but it's 40%. It's to reinsert the nasogastric tube. I mean, it's heavy duty. 40% they need again the nasogastric tube, and it's not easy to pass again the nasogastric tube. Not for the doctor, for the patient if he is awake.
Yeah.
But maybe if we leave it in. For
the other patient, you leave it.
For 60%. Okay.
For 60%.
Okay.
When you leave it for a long time. You never remove it at day 2 or 3 because it's always producing. So the patient will stay 1 week with the nasogastric tube. I mean, it's a balance. In our experience, we never had problem with patient for reinserting in nasogastric tube.
Yes. Okay.
The patient accepted quite well. But it's always the same. If you explain to the patient before the surgery that he will not have a tube, but probably we may need to put it at day 2 or 3. He will not
this
be
is
very
the best
upset.
idea. Yes, this is
And
right.
this is that is why it's very important to give as much as you can for the information. And also the nurse coordinator of the ERAS program, they spend almost 45 or 1 hour with each patient before, several days before surgery, to explain all these aspects.
Well, yes, please.
Thank you very much for your excellent lecture presentation. You said that you are starting to oral feeding with liquid at the same day of the operation. I would like to know, is there any limit for this? What amount of liquid you are giving to the patient during the first day or first?
The first day we propose water or some apple juice, clear fluid, okay? But it's always the patient who decides. Okay, so we give him 250 milliliter of clear fluid, and he drinks what he wants. If he don't drink anything, it's not a problem. If he finish all of them and he's happy, it's okay for us. If he take half of them, you have to think that the patient is the best to know what he can take orally.
So that's meaning is the upper limit is 250 or?
We never had a patient who drink 2 liters after whipping. Yeah.
Thank you.
Yes, please.
And thank you, Mr. Adam, for your nice presentation. I would again like to ask you the drain amylase level. You said 5,000, right? Or
yeah.
5,000. Okay. We are HBB surgeons and liver transplant surgeons. We think we are brave men, but I think to push forward and to step forward, we have to be more brave after your nice lecture. And also one comment in your excellent last slide. There were 2 groups, 2 teams.
Yeah.
You didn't give the p-value between the groups.
Yeah.
Thank you.
Yes, please.
Thank you very much for your good presentation. I have 2 questions. One of them is for the texture of the pancreas. For your experience in the perioperatively, how could you, what about the tips and tricks for the texture of the pancreas? What do you say is as to take home message? This is soft, or this is hard, or this is medium? And the second one is, again, post-operative day 1, you say that the patient can get normal diet, the start to eat, oral intake. Is there any foods or fluids, do you advise us as a take-home message, forbidden, maybe the hot foods, or maybe the spicy foods, or maybe the foods that are distension about the patient, or some foods there you have to say we have to make the patient brave to eat, like yogurt or the other clear fluids. Thank you very much.
Okay, for the pancreas, I think it's always a matter of surgical, subjective. Okay, the soft, the medium, and the hard pancreas. If you take pancreas, you show it for 10 surgeons. One will be soft, one will be medium, one. Okay, so this depends on the experience. The size of the main pancreatic duct, we can measure it. So no discussion about it. In our experience, when we look for the now we use the selective drainage. In pancreatic head cancer, we drain almost 60% of the patient, okay, because they have either small main duct or soft or normal pancreas. We only do not put drain if we have large duct and we have a very firm pancreas. Otherwise, we put drain. And then for the feeding, when we say we start normal feeding, they don't have kebab on the next day. Okay, let's be clear. They start by liquid. They have oral nutritional support. Okay, they have to take 3 bottles of 200 milli of the nutritional supplement, and then we start by soft food. Okay, and then we increase with the patient need.
What's the normal value of the serum amylase in your hospital?
Normal value?
Yes, of the serum amylase in your hospital.
They change every couple of years.
Okay, so I think that the other way to be safe to remove the drainage is 3 times the amylase over the serum amylase. So,
of course, we measure both in the blood and in the drain, but in fact we look more in the amylase in the drain unless the patient have pancreatitis. Some patients have pancreatitis after surgery with high lipase level, so it's not the same meaning of the amylase in the drain if the patient had pancreatitis.
5,000 amylase in the drainage is too much. I mean, it's better to compare with the blood amylase and what's the direction from the European
could be
study group of pancreatic surgery.
And we do the amylase and the lipase also.
Lipase also.
Because the problem we have in our hospital is that the biochemistry, they stop measuring the amylase in the blood. They say it's useless, we should not do it. And a lot of discussion for the pancreatic fistula. So we measure lipase and amylase in the drain, and we look for the lipase in the blood.
Yes, please.
Thank you for your nice presentation. I have 2 questions. The first one is that your protocol for ICU admission of the patients after major pancreatic surgeries. Do you transfer all the patients to ICU or not? The second question, what is your protocol for DVT prophylaxis after major pancreatic surgeries?
The patient, they don't go to ICU or high dependency care unit unless they have medical problem, respiratory need for ventilation, or they have myocardial insufficiency or things like this. Otherwise, they go back to the surgery ward. So they don't go, I mean, as first intention to ICU or high dependency, no. We used to do this many years ago, and then we stopped, and we feel that the patients are doing better in the surgery ward when they don't need to go to the ICU. So very, very rare. I think more than 97 or 98% of our patients go back to the surgery directly after the whip.
Okay, we have two more questions, and
yeah, it's we use the same. We use normal thromboprophylaxis as any normal patient.
For a month. For a month.
We usually use for 1 month. Yeah, for 1 month, especially if it is cancer patient.
Thank you for perfect presentation. You showed us some guidelines about perioperative nutrition from ESPEN, but we know that they published new version of guidelines about perioperative nutrition, and if we compare 2 versions, we have some changes. Important one is that immunonutrition. Immunonutrition was grade A recommendation in old version, now grade B recommendation. And the other changes is that if your patient in severe malnutrition before operation, you can give some oral supplements, standard oral supplements versus immunonutrients. There are some big changes about perioperative nutrition support. What do you think about these changes?
Yeah, I totally agree. Immunonutrition, we have a lot of debate. I personally don't believe in immunonutrition because no one can explain how it works or why it's better, etc. And all the publication, when we look very carefully for the publication on immunonutrition, there are a lot of biases in this publication. Recently, the team of Heidelberg from Marcus Buschler, they published a systematic review on the perioperative nutrition, and they show clearly that immunonutrition has no benefit in these cases. The only thing is that maybe in some cancer patient it could be, bring something. That is why in our protocol we have a lot of discussion recently about this, and the recommendation of the society in France is to give immunonutrition. I think there is a lot of lobbying around it also. Okay. But we decided to use immunonutrition only for cancer patients when they have undernutrition. Otherwise, we don't use it, trying to be close to the existing recommendation. But I think this will change. I think the best thing is the oral food. This is as long as the patient can eat, this is the best way to.
But nowadays there are so few the patients that they are coming in undernutrition situation. I mean, it's changed. 20 years ago, yes.
We have less,
Yes, now it's. Okay, and the last one.
Last one. Now the questions are kind of comments. I believe the decision of whether or not just you remove the drain, put the drain, or take the patient to a high dependency unit or to the ward, it depends on your resources. This depends on your resources and your capabilities of the hospital also. If you have a very good team of interventional radiology who are able to put drains even beneath the anastomosis, beneath the vessels, where the collections occur after the Whipple procedure, you can completely avoid the drains, right? I mean, you can completely avoid the drains.
I think that the issue of drains is another lecture about 2 hours. And I have, it's a little bit a diplomatic answer that selective patients put the drain or not the drain. And fistula, pancreatic fistula stage 1, it's 15%, 20%. In my head, it's 30%. And it's also, he is right. If you don't have the interventional radiologist, then it's too risky not to put drainage.
I think you're right. If you have interventional radiologists, you feel more comfortable not putting the drain because you know that someone can do it after surgery. But if we look very closely to the data, there is almost no difference between the interventional procedure in patient with or without drain. So even patient with drain, after 48 hours, the drain are excluded, and if the fistula or you have abscess later on, you may have always to redrain the patient.
Okay. Thank you very much to all of you and Professor.